I'm not actually going to talk that much about Wales. And if you know me, you know why. But I am, yes, I'm speaking on behalf of Digital Healthcare Wales for the time being. I'm pleased to be here. I was going to try and do an icebreaker, largely because you've all had lunch and we don't want any lethargy kicking in. So if I start shouting or pointing at people, wave your hands, you're just going to have to roll with it, because that's what I'm doing. So I'm going to start with this, which didn't work because I didn't embed the damn fonts. Who else has found that as a problem if you didn't embed your fonts? Anyway, enough with the damn standards. Why are we talking about damn data standards constantly? I've served 20 years working in the NHS, and I've talked about data standards probably for 20 years. And it never gets old. When is the damn coffee, though? That's also very important. You know, data standards come in different shapes and sizes. This is an example of a data standard that I keep on wheeling out because it never gets old. So this is real. Diabetes equals no is a real data standard. Now, if anybody's trying to build systems, build anything tangible with that, you can't have diabetes equals no. That doesn't make any sense. Diet, tablets, insulin, new diagnosis. We're talking about structures of data, levels of granularity that mean different things depending on what questions you're asking. So I'd say that this is a terrible example of a data standard, unless, of course, it's a statutory data return for cardiology, in which case it's a great data standard. So who am I to say such things? The problem that I've found is that we deal in absolutes, especially in the UK. We want that silver bullet. We want the solution. We want something to actually do whatever it is that we've got a problem with at that point in time. We naturally gravitate towards this as humans. We like absolutism. And there is no such thing as the silver bullet. So it's not about, especially interop data standards. Interop for me has been a bit of a white elephant over the years. Sorry, slightly provocative. I don't want anybody to shout at me. But it's not about data standards. Where do standards come from? Now, in my experience, we've got data standards that come from a variety of different places. You might have, you know, like the previous example, a statutory data return for cardiology data set. You might have health surveillance and disease tracking, government incentives, consumer demand. So, you know, data standards come from the fact that I've got this watch and it's made by Garmin and there is data that flows in and out and so on and so forth. Standardized clinical terminologies. The government thing's an interesting angle. Years and years ago, I found myself in the offices of the Welsh Government where we were talking about smoking cessation stats. So we wanted to figure out how many mothers who were smoking when they became pregnant gave up. And then they wanted a metric to figure out whether or not their smoking cessation initiatives were working. And they just were literally looking at one number in the beginning and one number at the end and going, hooray, the numbers have reduced. Because there was no semantic alignment to that data. We didn't know when the intervention happened because we weren't capturing how many mothers were being sent for smoking cessation to start with. And then we had the other problem, which was we couldn't even implement it in the system because the data just didn't align. Or it aligned in some systems, not other systems. And at that time, we had 5 different systems across Wales. So, you know, I was sitting in front of somebody saying, we can't do it. We can't give you this data. Why can't you? We've demanded it. We are the government, so on and so forth. They never got the data, you know. And this has led me to thinking, you know, in the darkest recesses of my mind late at night about the drift of traditional data definitions. I bet nobody else has ever said that before. If you think about how data happens, where does it come from? You know, you know, it has to be defined somewhere. Okay, I think we can all agree that. And then it gets generated, somebody does something, you store it in a system, you might transform it, and you might reuse it. And all of those things make sense. I've noticed a pattern, though. There seems to be this idea that if you're at the end of this, we've got data, it sits somewhere, fantastic. You want to reuse it. Okay, you can reuse it sometimes. And this is where I say it's not about interoperability data standards. Because for simple use cases, yeah, sure, you might be able to get something to work. It makes sense to a certain extent that if you could define something and maybe put a lovely SNOMED code on it and everyone agrees that's the code we're going to use, okay, that's all right. You've got a unit of measure, you've got the actual, you know, the actual measurement itself. That can kind of make sense. But when you start broadening out the use case, when you start doing something like, well, build a longitudinal health record, for example, you then start to stretch those definitions. And in reality, what we do as human beings, when we all get in a room, we actually dumb it down. We actually need to conform. We reach consensus. And when you do conform, you find that you have to go back to the drawing board. Well, okay, that's fine. We can deal with that. You can deprecate APIs, right? You know, this is just us learning and growing and being better at digital and all that kind of like stuff. The problem is the domino effect. The problem is that when you redefine something, you basically nuke everything that's going to be in that way. Everything that goes down to data reuse. Data definitions will vary. This is the business we're in. There's nothing new about this. Sorry, I'm stating the bleeding obvious to a room of people that already know this, but I feel like I've got to labour the point. Because, you know, we have to be able to roll with the punches in terms of how clinical and care practice and processes evolve over time. This is just the nature of it. And that's why you have to have something that is malleable underneath the hood in terms of the ability to structure data and define what those data structures invariably look like. That's life. Again, a font didn't work properly. It was supposed to be a nice cursive font. This joke has not landed. Doesn't matter. You know, this is just the nature of things. There's no point in us trying to rail against this, okay? However, we could choose our tools a little bit differently. So I've started thinking about different way of sort of like looking at things. And I've started using the word capability largely because of my colleague Rian Rice, who's sitting there on the fourth row, as a surrogate for saying data standards. Lots of us will find that we've been in a room, we've spoken to people, and we say, oh, FHIR is a data standard, openEHR is a data standard. No, it's not. These are frameworks. In the last session, it was described by a gentleman from the representing IEEE. They used the word frameworks. I can, you know, I'd say foundational capabilities, but you know, semantics are important in regards to this, and this is why we constantly have this circular argument, because the people that don't understand the complexity of this, you know, it's not worth our time or you know, or the effort sometimes to have these conversations because they haven't built stuff. They haven't been through this process. They don't understand the intricacies of clinical care. So for me, I've started to think about, well, you know, if we think about structured data and documents and unstructured data and images and things like that, they are the outputs of us getting the foundations right. And if I follow my train of thought, right up the top there, you've got interoperability that sits there as an application of data. Most of the diagrams I've done in my experience, and we see lots of these, you insert interoperability below the application, don't you? Because an application consumes data from an interoperability perspective. But of course, interoperability is an application. It is a use case. System A needs to send data to System B. System B needs to understand what that is. It's just a different way of looking at it. It might as well be a screen. You know, it might as well be something you present, you know, in a GUI to a clinician or so on and so forth. So the future of data standards, really for me, is not about the things we call the data standards. It's about the foundations. It's about getting these things right. So that's where openEHR sits, and that's where FHIR sits, and that's where SNOMED sits, and LOINC, so on and so on. So it's about the toolkit approach, which is an absolutely abhorrent ChatGPT image. You can see, because in the corner here, we've got this weird spannery adjustable hammer thing, which is, I don't know. And I thought about getting rid of it, and I thought, let's just roll with it anyway. Hey, if that could be the future of HL7 and openEHR collaboration, you never know. You know, it could be a super interoperable hammer spanner that has to be adjustable by design. So this leads me down the path to public digital infrastructure. The ability for us to actually start to develop a series of building blocks that are the plumbing, the electricity, that are reusable components. And of course, we do have some of this already. Heather Leslie did some analysis like 5 years ago, 16,000 human hours, I keep getting that wrong, person hours to develop what was in the clinical knowledge manager at that time. And now it's probably doubled. Okay, that's a huge resource. And it's right over there at the end of your web browser, and you're able to make use of it. That's public digital infrastructure. So I'm going to leave with this, which is that, that's Lionel Richie, by the way, just checking, yeah? The The future of data standards is about how we harness these capabilities, how we harness this public digital infrastructure. So when somebody picks up the phone and says, hello, is it me you're looking for? I say, well, is it data standards? Is it interoperability? Is it persistence? Whatever it happens to be. But us as a community have to be picking up the phone together. We have to be talking together. Otherwise, we're just going to rinse and repeat what we've been doing for the last 10, 15 years, or at least the 20 years that I've been involved in this rat race we call digital health. Anyway, that's me. Thank you.
So, shall I go next? Great. Well, I made the same, well, I didn't know if this was a rookie mistake, but I didn't check the fonts either, so this is going to be nice, whether this works at all. Anyway, I just got a new set of PowerPoint layouts from our marketing department, so this will be a great check whether this works universally on presentation laptops. Anyway, welcome. For those who were with me in the last session, who were there in the last session where I talked? Oh, crap. That's a lot of people. You notice the title is the same, and that's no coincidence. So you're officially entitled this time, only this time, to read your emails while I do a summary of what you've already been hearing. And for the others, welcome. I'm going to talk about the future cooperation between openEHR and HL7. And I'm going to try to really avoid making the same jokes again that I did in the last session. So the future cooperation between openEHR and HL7 is a thing, and I mentioned there are tons of questions about it. So I'm really happy that I'm here for today and tomorrow to discuss this cooperation between openEHR and HL7. I'm going to talk a little bit about what it is and what it is not, and where we are, and more or less what we think we're going to work on. So let's first start with introducing myself. My name is Ewout Kramer. I am a CTO of FHIR, and we're a company producing FHIR-based software, so FHIR service and so on and so on. That's probably not, for this discussion, not the most important thing. I am also, or I was, a software engineer. A growing company also means that I tend to do more as a CTO, more and more work, apart from software engineering, writing PowerPoints and so on like this one. But I was a software engineer, and I think that's important. It's in my nature, and it was as a software engineer that I got involved in data standards. I didn't know anything about data standards, but then someone in the Netherlands showed me these beautiful red, yellow, green, blue pictures that belong to a standard called HL7 v3. And I was totally fascinated. I learned everything about it, and I also learned everything about openEHR, at least what we had at that moment in time, which is about a good 15 years ago. So, be gentle to me. I'm not an open-air expert. I do know a fair bit about it, but I know way more about FHIR, because what happened is I got involved in a big HL7 v3 project, and it totally failed, even though we had smart people and a lot of budget. And that prompted me to start working on something else, and it wasn't called FHIR back then, with Graham Grieve and Lloyd McKenzie. And that group quickly grew with other smart individuals that we borrowed from the HL7 community. And so FHIR was born. It was called Resources for Health first, but that was a WHO thing. Anyway, so I am also responsible for quite a bit of the FHIR specification. So it means that I'm fully aware that what I'm presenting here is a lookout from the HL7 side. I'm here to open the discussion about the cooperation between these two organizations. And so if I'm saying anything about openEHR that isn't 100% correct, that's just because my knowledge is 15 years old. Anyway, HL7 International and openEHR, this on May 23rd, 2024, HL7 and openEHR together published a press release announcing their cooperation. At least that's what I understood. But when I read the press release again, I noticed that the wording was chosen very carefully. So HL7 International and openEHR International are pleased to inform that we are jointly considering aligning, right? So that is careful. we are jointly considering aligning. We start to, like sniff at each other a little bit whether we can work together. And I know we can, right? I visited openEHR, the last year's conference in Arnhem was really inspiring to me. There's a second thing there, and it's even more careful. We are announcing an intention to explore a closer collaboration. That's a lot of hoops to jump through. So there must be sensitivities going on here, you'd say, if you read these people have spent time on this. And so I think the most important thing that's in that press release is this last sentence. If we together decide to move forward, there's an if there, then even if we do, it will take time to build trust, develop approaches, and deliver outcomes. And I think that's a very reasonable thing to say. I enjoy being here, but it's not a natural thing that our communities cooperate. And I'm also aware that I'm at a disadvantage, and this group is actually at an advantage in the sense that when I'm at a FHIR conference asking who has been working with openEHR, then I won't see a lot of raised hands. But if I'm at a conference like this and I say, who's worked with FHIR, there will be a lot of raised hands. So this community already has a lot of experience in the combination of actually collaborating. So what process are we actually starting? There's already a lot of work done, and I hope that we can profit from that. So why would we do that? Of course, obviously, I think it's a really good idea for the world outside the confines of this, this room or the WGM, the HL7 room in Atlanta, where we all know the differences. But outside of this room, a lot of people are wondering, when should I use A and B? I mean, you must have been asked these questions. What is the difference between FHIR, openEHR, CDA, HL7 V2? We all know that, you're in health IT, okay, and so on. No, it would be better if these companies, or if these both organizations have a consistent story to tell there, one that doesn't stimulate myths. For the openEHR community, I think there's things to gain from some of the tooling and the experience in maintaining a standard. HL7 has been maintaining standards since V2 is an NC standards organization, and there's a lot of knowledge about how to have a process for dealing with changes to standards and so on and so on. And there's quite a lot of tooling around it too. The fact that HL7 is very good at this pretty fixed and stiff process also means that from the HL70 community can learn from the openEHR's open collaborative nature. Because I must say, a lot of FHIR is focused around the developer. In my previous session, I was talking about how, as a developer, I got frustrated with V3 because it was so complicated. So when I went on to design FHIR, we simplified a lot of things. We did away with the reference model, whether that was a good thing or not, we did. We introduced resources, extensions, everything you know about. And so a lot of our effort is geared towards developers and connectathons. But openEHR brings a collaborative culture with an extensive existing clinical model library and a lot of connection with clinicians and methodology. So I think we can benefit from that as well. A very practical example of collaboration was something I saw last year in Arnhem, which was my first meeting with the openEHR community in a long while. And there I saw a presentation by Siddharth, and he presented about smart and openEHR. And I wasn't sure I had heard about that before, and being new in the community or being renewed in openEHR, I was assuming everyone was already using this. I was like, this is such a good idea. And then I learned that this was just a very bold move also by Siddharth to combine the knowledge that we gathered in SMART and apply them to openEHR principles. And I think this is a really good example of something that where both organizations can benefit. And actually, it's not so much the organizations that benefit only, it's also the developers who are using our standards. Because having to implement the same thing twice, a totally different concept, that's a really costly thing to do. So everything that we manage to align is clearly and immediately a plus for developers. So since this was announced in May, in my previous presentation I said not a lot happened, but that's not really true. We formed committees, that's one thing, and obviously on, here on the openEHR side, there's already a lot of work and new projects starting to combine FHIR and openEHR. Again, I think there's a lot of knowledge in this community already. And so we have the strategic group with these names, Graham and Rachel are there, and Ian is also present here. I've seen Stefan. A lot of people from the openEHR group are here. From the HL7 technical group, I have myself at the bottom and Jean, who is over there in the blue shirt. And so the reason that we are here is that we are here to start this discussion, to open these doors, to actually start working on the trust that I mentioned on the first slide, and to gather input for these two technical groups to sit together and say, hey, what are the things that we can start working on aligning? And I just want to show you some of the ideas. I already mentioned one of the things we're probably going to look at is process, the HL7 process versus the more exploratory openEHR community and the clinical involvement. How can we profit from those two things? We're definitely going to look at publishing international patient summary archetypes. So international patient summary is a set of profiles, a set of FHIR profiles, a FHIR implementation guide written by the FHIR community, HL7, but we want to look at producing appendices to these that actually specify how this data is going to be, in archetypes, how you can use archetypes in openEHR to communicate and to store the same data. One of the most important things to make that work is a big frustration for a lot of people I spoke to is that our data types don't map. And we might not be able to actually map them from one to the other because ours are normative and in use everywhere and yours are too, but at least talking about best practices on mapping them. Integrating terminology stacks. I think FHIR has a very strong terminology stack. We have an SDK or an API to query servers for terminologies, and that is definitely something that both organizations can profit from. Our IG publisher, or the notion that developers, how many time do we have left? Oh, right.
Where's Dan?
So the concept of an implementation guide is an important one, which is like a document for a developer, not containing just the models, but also how to implement it, and so on and so on. That makes it, and I'll skip the mapping of profiles and archetypes, the most interesting thing on this slide, and I'll do that on purpose, because we'll still have 2 days to discuss this. And again, I have no illusion that the slides that I'm having here are the full story. We're just starting this journey here. We're in the phase where the committees will talk to each other, where we will look at how we can cooperate and so on. And so this is actually the starting signal, the starting presentation, as far as I'm concerned, for this collaboration. And we can start right here during the drinks, in the hallways, and the fireworks. Thanks. And then I think it's up to Don to get to the mic.
Thank you. So I will break with tradition. There will be no boring slides. I want to thank Rachel and her team for putting on this conference. I think they deserve a round of applause. They did a great job. I want to thank all of you who all have busy days and you're taking your time out to be here, so I'm not going to try and bore you or spend 15 minutes talking about things. I want to talk about 2 things. First, SNOMED International recognizes that we need to collaborate with openEHR. And we're in the process of formalizing agreement with openEHR. And as part of that, there will be free use of SNOMED in everything that openEHR does in order for them to prosper and succeed. And hopefully we'll set up joint community of practice groups so that we can actually hold hands, work together, and get some things done. Now, on to the topic at hand, the future of standards. So if you look at the speakers this morning, it's quite clear that the future is now, and if it's not now, it's coming very quickly. So let's go back. We had a pandemic. Governments were in a tizzy. They couldn't get the data. They didn't know what they needed. And they reached out and found standards organizations that could help them manage the pandemic. And so from that perspective, we have government's attention. And in order for standards organizations to survive, they need to do two things. One, they need a global fund so that all standards organizations that are used globally can have the adequate funding in order to do their work and future-proof what is happening. That's the first thing, and there are discussions that are happening. Secondly, the standards organizations need to put their egos aside and start to work together. And for too long, standards organizations, including the one that I run now, had egos and didn't want to talk to anybody. Those days are long gone. And so my organization is here to collaborate with the openEHR community, with the HL7 community, and any other standards that can fit together to solve the problem, which is to help the patient. That's the most important thing. But it doesn't really stop there. During the pandemic and the ensuing climate crisis, the one thing that I found in my home province in Canada, a small little province, Nova Scotia, which translates into New Scotland, so there is a UK tie there, was the fact that we had wildfires, huge wildfires. We had huge floods. We have homeless people living in tents. And governments are struggling to determine how they can get the data in order to protect those people. And right now, it's not just health departments that are consuming the data or regional health authorities or hospitals or primary care, it's municipalities. So I urge everyone who is in this room to start thinking outside the box, because what's going to happen is the requests for data are not just going to come from federal governments or local governments. They're going to come from other sources, and they're going to want the data that they can easily consume, consider it to be correct in order for them to protect their population. Whether that's identifying mobility issues so that they can evacuate people, or whether it's to deal with preventive health care for those in homeless camps who may end up costing the system tens of millions of dollars down the road. But there is a bright light. We have another partner that we don't really spend a lot of time with, but we need to spend more time with, and that's the private sector. The private sector innovates. We may not like them. Some we do, some we don't. But they can help us. And we need to have discussions with them in order to find out what their needs are in order to meet their requirements that governments put on them. But we also need to talk to our populations. I have my own health record. In fact, I have one in the United Kingdom, and I have one back in my home province. And I'm an engaged patient. When I go to my doctor's office, I grill my doctor after I tell him what my issue is and he gives me a diagnosis. I want to know not what his suggestion for treatment is, but what my options are. And not only what my options are, but how is it going to impact me short-term and long-term, if it relates to pain management or mobility or something else, but what's it going to do for me long-term? And I do my research going in, and I'm helped by the fact that I have data in my apps that I can trust. And we need to get there. And I'll close by using a personal example of two examples. One is good, one is bad. So I'll start with the bad. So 40 years ago, I started this journey in healthcare. And 5 years after I started this journey, I got this phone call from my father, who had never seen a doctor and had gone in for some tests for cancer. He went to one hospital, And they did the test, and they said they would call him. And then I got a phone call in the middle of the night from him crying because he was told he had to go in and have his bladder removed on the Tuesday morning, and this was a Saturday night. And I asked him, so did you get the test results? And he said, no, I just got a call from a clinician. So the next day, I phoned the said clinician and said, so my father's having surgery? Yes. Removing the bladder? Yes. So how does tests go? And the doctor said, well, what test? And I said, well, you were the doctor on the other side in the other hospital that did that test. What are the results? And he just stopped and he said, come see me tomorrow. So I went to his office and he said he apologized because of paper, the information never got to his office in the cancer center. It was only in the other hospital. And my father was cancer-free. So needless to say, he didn't get the operation. But if you look forward and you look where we are now, I was in the UK in 2021. And like every good Canadian, it was a Sunday, roast dinner. I had a few beers. I took my first bite of roast beef, and it got caught in my throat. Luckily, there was a marathon ongoing. People next to me at the table, they rushed over, they did the Heimlich maneuver, which saved my life, but it also had some complications, which is I could breathe, but I couldn't talk because the roast beef was stuck in my throat. So they called for the paramedics who were at the finish line of the London Marathon, and they came running over, and they tried everything, and it didn't work. So they took me to the ambulance. And of course, I couldn't talk, but I had my partner with me, and they asked her, does he have an NHS number? She goes, yes. And so, what's your name and birth date? So she gave the name and birth date, and they go, here's your record. You're not allergic to anything. And here are your conditions. Let's take you to the London hospital and get fixed. And they fixed me at the London hospital. But it goes to show that information within context needs to be moved rather quickly or accessed rather quickly to save lives. And I think everyone in this room would agree the future of where we're going from standards is to keep that front of mind. We're here to help people. We're here to collaborate and cooperate and work together to get things done. And if we need to, we can be a force to be reckoned with if we need to sit in front of governments and ask them for more money for us to do the jobs that are important to save patients' lives. Thank you very much.